Good evening friends, welcome to my channel Critical Care Basics. In the last 3 lectures before this, we were discussing about the management of acute pancreatitis in ICU. So this is the last and 4th lecture on the treatment of acute pancreatitis. We have seen about the definition of pancreatitis, the 2 types of pancreatitis, and the various classifications to assess various scores to assess the severity of pancreatitis, and then about the treatment of pancreatitis, part 1. In this second part, we will discuss about the treatment of complications of pancreatitis. So let's begin. Acute pancreatitis part 4. So the commonest one is acute peripancreatic fluid collection. So these fluid collections usually develop in the early phase of pancreatitis, and they usually remain asymptomatic and usually resolve spontaneously without any need for drainage. So this is the most fortunate scenario to happen. Most acute fluid collection resolve within 7 to 10 days, while only about 7% of acute pancreatic fluid collection persist for more than 4 weeks. Then they are called as pseudocysts. Here you can see the fluid collection, and this is resolved. A lot of fluid collection here. This is resolved by day 12. The problem comes when the fluid gets infected or there is a necrosis which gets infected. So this is a dangerous thing, leading cause of morbidity and mortality in acute necrotizing pancreatitis. Approximately 1/3 of patients with pancreatic necrosis develop infected necrosis. There is no correlation between the extent of necrosis and the risk of infection. Even the small part, necrotic part, may get infected. Although infection can occur early in the course of disease, in the course of pancreatitis, it is much more common in the late clinical presentation, that is after 10 days. Now, infected necrosis should be suspected in patients with pancreatic or extrapancreatic necrosis who deteriorate, right? So if they become hemodynamically unstable, or the sepsis escalates, or there is increase in SIRS criteria, or increasing WBC count, fever, or the patients fail to recover even after 7 to 10 days of hospitalization. Clinical signs of infection and abdominal imaging demonstrating gas within the necrosis. You can see here, this is the whole necrosis, and you can see gas within the necrosis. This is highly suggestive of infected necrosis. Suggestive of infection and antibiotic therapy. If you see a CT picture like this, you can start antibiotics without going for culture, aspiration and culture. If empirical antibiotics are started, right, the antibiotics known to penetrate pancreatic necrosis should be used. Example, carbapenems or quinolones or ceftazidime or cefepime. Gentamicin does not have that much penetration into pancreas, so that should be avoided. Also use anaerobic cover in form of metronidazole. The infected necrosis usually has organisms. It is usually monomicrobial, and the organisms are usually derived from gut, like E. coli, Pseudomonas, Klebsiella and Enterococcus. This is in approximately 75% of cases. However, the incidence of gram-positive, multi-drug resistant and fungal organisms is increasing. Now, in patients who fail to improve, you thought that the patient has deteriorated, you got a CT scan done, CT showed some air in the necrotic tissue, so you started on antibiotics, and even after 48 to 72 hours, the patient has not shown any sign of improvement. In fact, the patient has actually deteriorated. Then you can perform drainage or debridement of pancreatic necrosis, what is called as necrosectomy. Or you could do CT guided aspiration in patients who fail to improve in order to guide antibiotic treatment before drainage and debridement. So you could do CT guided aspiration for culture, and then you could go ahead with drainage and debridement. In stable patient with infected necrosis, attempt to delay. If the patient is stable, right, do not go invasively. So try to delay drainage for at least 4 weeks. Continue conservative management of necrotic fluid collection allows minimally invasive debridement. So if the patient tolerates 4 weeks of conservative treatment with antibiotics and remains stable, then you could probably do a smaller procedure, minimally invasive debridement, and that could be less invasive and less problematic for the patient. Even some patients with infected necrosis clinically improve to an extent that intervention may not be necessary. Interim percutaneous drainage may be needed in patients with infected necrosis who exhibit clinical deterioration or fail to improve but do not have walled off necrotic collection. So if the patients are not improving but they don't have walled off necrosis in CT scan, so you can do interim percutaneous drainage. So this is a flow chart of just what we have just discussed. Suppose the patient has necrotizing pancreatitis and there is clinical deterioration. Perform a contrast enhanced CT scan. If you see gas formation, then there is high suspicion of infected necrosis. Start antibiotics, start treatment, evaluate. If the patient improves, no problem, continue conservative treatment and evaluate treatment regularly. If the patient does not improve, then you may require to go for repeat CT scan and some necrostomy or CT guided aspiration. If the necrotizing collection does not show gas formation, then evaluate and treat other causes. Like the patient has deteriorated, patient is looking like he has infection, see for whether the patient has lung infection or urinary infection. If that is the case, treat. And if you do not find any other source of infection, perform fine needle aspiration. And if it is negative, remain conservative, evaluate and continue conservative treatment. If FNA, fine needle aspiration culture, shows bacteria growth, then go ahead in this pathway and start with antibiotic treatment. If the necrosis is sterile, your fine needle aspiration comes negative. If the aspirated material on CT guided FNA is sterile, then discontinue. This is the most difficult step because most of the physicians are not willing to stop antibiotic. Discontinue antibiotics and continue conservative treatment for 4 to 6 weeks, because the use of antibiotics in patient with sterile necrosis to prevent the development of infected necrosis is not recommended. So sterile necrosis does not require any treatment. Right? So if the FNA is negative, then stop antibiotics. So are there any indications for interventions in sterile necrosis? There are some. If there is ongoing gastric outlet, intestinal or biliary obstruction. So if the necrosis is causing mass effect and obstruction due to mass effect at least 4 weeks after the onset of acute pancreatitis, then you may have to intervene. If there are persistent symptoms like abdominal pain, nausea, vomiting, anorexia, weight loss or increased satiety after 8 weeks, then you may require to intervene. Or disconnected duct syndrome, that is full transection of the pancreatic duct with persistent symptomatic collection, example pain or obstruction more than 4 weeks after the onset of pancreatitis. These are the few indications when you will have to intervene even in sterile necrosis. So these are the general measures for all patients with walled off pancreatic fluid necrosis. First is nutrition. So take a proper nutritional consultation. For patients who are tolerating oral intake, start with low fat consisting of small frequent meals. So low fat meals and small frequent meals. For patients who do not tolerate oral intake, start with rice stew feeds. For patient with walled off pancreatic fluid collection, nasogastric feeding may reduce the need for endoscopic intervention. So if the proper nutrition is given, maybe the patient will improve and endoscopic interventions may not be required by relieving pain and improving nutritional status. Of course, you have to tell the patient to avoid alcohol, and the patient requires multidisciplinary care with gastroenterology, interventional radiology and surgery working together. If the patient is asymptomatic without any complications, then observe clinically, follow up a CT scan or MRI after 3 to 6 months. If the pseudocyst resolution or decrease in cyst size, then follow up, and we need not do further imaging studies, but imaging studies should be repeated sooner than 3 months. So if the cyst size has reduced or the patient is asymptomatic, you need not repeat this imaging study like a CT scan or MRI for at least 3 months, but imaging should be repeated sooner than 3 months if the patient develops symptoms such as abdominal pain, jaundice, or early satiety or fever. So early satiety means the cyst is pressing the stomach and the patient is not able to eat. So if such symptoms develop, then you may require to get imaging early. Spontaneous resolution of pancreatic cirrhosis is from 8 to 70%. So there is a high chance that the pseudocyst will resolve spontaneously. So when do we require drainage of the pseudocyst or walled off necrosis? Drainage in patients with symptoms or complications. So drainage of mature walled off pancreatic fluid collections is indicated for patients with either symptoms and or complications. So what are the symptoms? Persistent abdominal pain, nausea or vomiting, early satiety or anorexia, weight loss, and jaundice. And what are the complications? Infection, bleeding, obstruction, either gastric outlet obstruction, duodenal obstruction, or biliary obstruction. So any of these things occur, then you may require imaging and intervention. So what is the approach to drainage? So the choice of intervention is individualized and based on multiple factors like cyst characteristic. Where is the cyst? What is the extent of communication with the pancreatic duct? Whether there is presence of walled off necrosis, whether there is pancreatic duct stricture or biliary obstruction, and what is the hemodynamic status of the patient. And prior to intervention, pre-procedure evaluation with CT scan with early imaging during the arterial phase to rule out pseudoaneurysm. We'll come to pseudoaneurysm. This is a must. So contrast enhanced CT scan with evaluation during the arterial phase is a must before doing the interventions. So what are the interventions? If the pancreatic cirrhosis without complications, if it is simple cirrhosis, then endoscopic ultrasound guided transmural drainage, it is effective, has lower morbidity and no drains. We'll show pictorial images also. If there is walled off necrosis plus minus infection, then endoscopic ultrasound guided transmural drainage followed by direct endoscopic necrosectomy. Or pancreatic duct stricture associated with walled off PFC. So endoscopic ultrasound guided transmural drainage plus ERCP. Because why ERCP? Because here is a stricture in the pancreatic duct or the biliary duct. So ERCP guided transpapillary stent placement and drainage, right? So these are the images. This is the endoscopic guided, this is the pigtail stent from transmural from stomach into the necrosis, and through it you can drain. This is a percutaneous drain, this is a pigtail retractor, and you can use a videoscope also, and you can directly drain the necrosis or the cyst. Again, percutaneous procedure, image guided pigtail, then dilatation, direct endoscopic necrostomy, or you can put a self-expandable metal stent and through it you can percutaneous direct endoscopic necrosectomy can be done. Sometimes pancreatic pseudocyst communicating with the main pancreatic duct. So this is a pseudocyst and it is communicating with the main pancreatic duct. So in that case, you will have to put a transpapillary pancreatic stent. Through the papilla, you will have to put a pancreatic stent. Placement of the transpapillary stent provides continuous drainage of the pancreatic fluid and facilitates resolution of the pancreatic ductal disruption that is responsible for the pseudocyst. So the pancreatic ductal disruption was causing the pseudocyst. So if you put a transpapillary stent, that will help for the resolution. Now, if there is biliary obstruction related to pancreatic fluid collection, then the procedure of choice is endoscopic retrograde cholangiopancreatography with biliary sphincterotomy and biliary stent placement. So this is the stomach, you are coming to the duodenum, this is the endoscope, and this is the sphincter. So you can do sphincterotomy, or you can put a stent, or you can remove the stone. Drainage of the walled off necrosis. If the fluid collection resolves, then repeat cholangiogram, you remove the stone and put a stent. So if the fluid collection resolves, then repeat cholangiogram and you can remove the biliary stent. If there is walled off necrosis of or pancreatic fluid collection extending beyond the peripancreatic space, then you can do endoscopic drainage or percutaneous drainage like we saw in the last slide. Patient with walled off PFC is requiring drainage who cannot tolerate anesthesia. The patient is very sick. Then you can do radiologically guided percutaneous drainage. So that was about the various procedure that that are used to remove the pancreatic fluid collection or the pseudocyst or walled off necrosis. So now there are some other complications which are also dangerous. The first one is splanchnic venous thrombosis. So splanchnic venous thrombosis can involve the splenic, portal and or superior mesenteric veins and is incidentally found on imaging in 1 to 24 or up to 1/4 of patient with acute pancreatitis. So treatment should focus on underlying pancreatitis, as effective treatment may result in spontaneous resolution of thrombosis. So this thrombosis is secondary to the cascade started due to inflammatory process. So if you control the inflammation, maybe there is spontaneous resolution. Anticoagulation should be initiated if there is extension of clot into the portal superior mesenteric vein resulting in hepatic decompensation or compromise of bowel perfusion. So if you think that the portal vein is getting involved or the superior mesenteric vein is getting involved causing bowel ischemia, then anticoagulation is required. If splenic vein thrombosis is established already, usually for after a few weeks of diagnosis of acute pancreatitis, with the collaterals are already formed, then probably anticoagulation is not required. In contrast with patient who has splanchnic venous thrombosis due to chronic pancreatitis, complications such as variceal bleeding are rare and therefore prophylactic splenectomy is not recommended. So in contrast to what happens in chronic pancreatitis, here in acute pancreatitis, this variceal bleeding is rare, so you do not require to do splenectomy. Pseudoaneurysm, another dangerous complication. There is erosion of peripancreatic or pancreatic artery into the pseudocyst. So the artery gets eroded into the pseudocyst. Naturally, there is a huge bleeding. Pseudocysts are rare but serious complication of acute pancreatitis. Should be suspected if patient with acute pancreatitis. In patient with acute pancreatitis, if there is unexplained GI bleed or sudden drop in hematocrit or sudden expansion of the pancreatic fluid collection. So what do we do? So if there is suspicion of pseudoaneurysm, get an endoscopy, if possible endoscopic hemostasis. If there is ongoing bleed, if the patient's hemodynamics are stable, then do an angiography or contrast enhanced CT scan. If you identify bleeding vessel, embolize it, and once the bleeding gets resolved, continue with medical treatment. If you do not see a specific bleeder, recurrent bleeding but the source is unknown, then further diagnostic procedures. If there is ongoing bleeding, then the last resort is surgery. If the patient has unstable hemodynamics, then the patient requires urgent operation. What operation? Partial pancreatectomy or vessel ligation. The next problem in acute pancreatitis is abdominal compartment syndrome. Abdominal compartment syndrome is defined, we have seen the slides in our last lecture, defined as a sustained intra-abdominal pressure more than 20 millimeters of mercury plus evidence of a new onset organ failure. So patient with severe acute pancreatitis are at increased risk of intra-abdominal hypertension and abdominal compartment syndrome because there is interstitial tissue edema, from secondly third spasm and aggressive fluid resuscitation, then peripancreatic inflammation, ascites and ileus. So all these factors together increase the intra-abdominal pressure and there is a risk of abdominal compartment syndrome. So patients in the intensive care unit should be monitored for potential abdominal compartment syndrome with serial measurements of urinary bladder pressure. How to do this we have seen in our last lecture. So what happens in acute pancreatitis? There is aggressive fluid treatment, vessel edema, fluid collection, ascites, increased intra-abdominal volume. Aggressive fluid treatment again causes increased pressure. There is abdominal pressure, reduced abdominal pain causing reduced abdominal wall compliance, which also contributes to abdominal compartment syndrome. And because of abdominal compartment syndrome, there is multiple system organ failure and it can lead to death. So what do we do in a patient with abdominal compartment syndrome? In patient with acute pancreatitis, monitor the intra-abdominal pressure, and as soon as the pressure goes above 12, start medical management to reduce intra-abdominal pressure. The abdominal compartment syndrome is defined as intra-abdominal pressure more than 20 millimeters of mercury, but you start intervention when the pressure goes above 12. So measure intra-abdominal pressure 4-hourly. At all point of time, try to keep the intra-abdominal pressure less than 15. So there is step 1, step 2, step 3, step 4. So as the patient worsens, you do more and more interventions. There are multifaceted interventions. First is evacuate intraluminal contents. For example, put a rice tube, flatus tube, then you give prokinetics, then you minimize the feeding, enteral nutrition. SOS, you can give enemas, or you can do endoscopic decompression, or if the pressure worsens, you can hold enteral feedings altogether. If there is a space occupying lesion or in the abdomen, get a USG, get a CT scan, and if there is a large cyst or large necrotic area, then you can do percutaneous cat drainage, or last resort is surgical evacuation. If the abdominal wall compliance is not good, you can give adequate sedation, remove constricting dressings, etc. Try to keep patient in head low position, reverse Trendelenburg. SOS, you can give neuromuscular blocking agents. Optimize fluids, avoid excessive resuscitation, aim 0 to negative fluid balance by day 3. So after initial moderate fluid resuscitation for 48 hours, then gradually reduce the fluid resuscitation so that the patient is 0 or negative balance by day 3. You can use hypertonic fluids now or even colloids. If possible, judicious use of diuretics if the patient is stable, and SOS you may go ahead with hemodialysis also if the output has dropped. Then optimize systemic and regional perfusion, goal directed resuscitation, and you can use hemodynamic monitoring. If intra-abdominal pressure is more than 25 plus organ dysfunction is not relieved with medical management, the last resort is surgical decompression. So once the patient of pancreatitis starts improving, then you have to treat the predisposing causes. In patient with gallstone pancreatitis, most stones pass into the duodenum. In a small proportion of patient, obstructive stones in the biliary tract or ampulla of Vater can cause persistent biliary and pancreatic duct obstruction leading to acute pancreatitis and cholangitis. So endoscope, here the ERCP comes into the role. ERCP should be performed early in the course of the disease, that is within 24 hours of admission for patient with gallstone pancreatitis and cholangitis. Cholangitis is diagnosed by Charcot's triad, fever, jaundice and abdominal pain. So if the patient has features of cholangitis and gallstone, then you should do early ERCP. There are some non-urgent indications for ERCP. Patient with common bile duct obstruction like visible stone on imaging or dilated common bile duct or increasing liver enzyme without cholangitis prior to elective cholecystectomy. So if there is a suspicion of stone in the CBD, get a ERCP done. In absence of common bile duct obstruction, ERCP is not indicated for mild to severe gallstone pancreatitis without cholangitis. So if there is no bile duct obstruction, then ERCP should not be done in mild to moderate pancreatitis provided there is no cholangitis. When in doubt about bile duct obstruction, in the absence of cholangitis, liver test can be rechecked 24 to 48 hours after. If they improve, or you can do a MRCP and endoscopic ultrasound, so to determine whether there are stones in the CBD. Indications for endoscopic ultrasound or MRCP prior to doing an ERCP. If there are persistent elevation, just like we talked in last slide, when there is persistent elevation of liver test and or dilatation of common bile duct without overt cholangitis, then do an MRCP or endoscopic ultrasound. In pregnant patient, you can do MRCP or endoscopic ultrasound. Altered anatomy that would make ERCP challenging. In such patient, you should do endoscopic ultrasound. In patients who are found to have stones on endoscopic ultrasound or MRCP, so you have to do ERCP with sphincterotomy and stone extraction is necessary and will prevent future attacks of biliary pancreatitis. However, in absence of cholecystectomy, these patients remain at risk for acute cholecystatic, biliary colic and gallbladder complications of cholelithiasis. So you are doing an ERCP, but later on it is better to do a cholecystectomy as well. ERCP is not a procedure without risks. So ERCP may aggravate the inflammatory process and carry risk of bacterial contamination, infection of necrosis, perforation, hemorrhage. So there are serious complications. So it should be done by the expert only. In patients with remote organ failures, including coagulopathy, ES may have a technical challenge. If there are alternative drainage mechanisms available, possible either endoscopically or inserted biliary catheter which bypasses or even dislodges the stone, then that could be done in place of ERCP. The incidence of post-ERCP pancreatitis may be decreased by placement of a pancreatic duct stent in high-risk patients. So you can put a duct stent. We have seen the diagram in last few slides back. You can put that duct stent so you avoid post-ERCP pancreatitis. Cholecystectomy should be performed after recovery in all patients with gallstone pancreatitis. So if your patient has gallstone pancreatitis, once the patient recovers, you have to do cholecystectomy, including those who have undergone an ERCP, to reduce the risk of recurrent pancreatitis. So even if you did ERCP, sphincterotomy or stone removal or a stenting, you should do a cholecystectomy because such patients remain at a risk of pancreatitis. In patients who have mild interstitial pancreatitis, cholecystectomy can be done in the same sitting, right, in the same hospital admission, index hospital admission. Or the patient who had moderate severe pancreatitis, in those interval cholecystectomy within 8 weeks is advised in necrotizing pancreatitis and when inflammation and fluid collection resolve or subside to a great extent. So if the patient had some peripancreatic collection, fluid collection, so once the fluids has resolved or reduced substantially and up to 6 to 7 weeks have passed, you get a cholecystectomy done. Failure to perform cholecystectomy is associated with 25 to 30% risk of recurrent acute pancreatitis, cholecystitis and or cholangitis within 6 to 8 weeks. So if you do not do cholecystectomy, the patient can have recurrent pancreatitis, cholecystitis, cholangitis. So there is risk if you do not do cholecystectomy in time. So if you plan to do a cholecystectomy, sometimes you are required to do a pre-op ERCP. The risk of recurrent pancreatitis is highest in patients who have not undergone sphincterotomy. So if there is a evidence of CBD dilatation or a stone or a stricture, so you may have to do a pre-op ERCP. If the clinical suspicion of common bile duct stones is high, example, there is a CBD stone on USG or CECT, or there is acute cholangitis or serum bilirubin is more than 4 milligram per deciliter and dilated CBD on USG, a preoperative ERCP is best and there is a high likelihood that the therapeutic intervention, that is sphincterotomy or stone extraction will be required. So patient at intermediate risk of CBD stone, that is age more than 55, abnormal LFTs, dilated CBD on USG, should undergo MRCP or endoscopic ultrasound to look for choledocholithiasis and if present then preoperative ERCP. So if you have suspicious like age is high, more than 55 and the patient has dilated CBD, or then get a endoscopic ultrasound or MRCP, and if it shows CBD stone, then get a ERCP, sphincterotomy and stone extraction. Biliary sludge. Most patients with biliary sludge are asymptomatic. So you may have seen a report of biliary sludge in sonography. There is no stone, but there is muddy material. However, biliary sludge is not uncommon in patients with acute pancreatitis with no other obvious cause. If the cause is not clear, perform endoscopic ultrasound even after one attack to look out for microlithiasis in gallbladder or bile ducts. So if there is biliary sludge in sonography, do an endoscopic ultrasound to see for small stones. Lastly, there are three major determinants of outcome in acute pancreatitis. One is the intensity of early amplification of inflammatory response. So these are the patients who become sick very fast and they develop in different complications like ARDS or severe sepsis. So these are the patients who have high mortality in the first phase or the acute phase. Then the development of and extent of local necrosis, and lastly secondary infections. So if the patient has necrosis, especially infected necrosis, then the morbidity and mortality is high. So thank you. That was in last 4 lectures. Now we have covered how to treat acute pancreatitis in ICU. I hope you're liking these lectures, and if you're liking, do subscribe, like and share. Thanks a lot. Bye bye.